Sensei, you have mentioned about the capillary perforator flap.
Yeah, yeah.
So how do you suggest that we can take such a huge 20 to 30 centimeter flap based on the capillary perforator? Is it because there is a high pressure in the capillaries compared to the normal perforator pressure? Is that's why it's perfusing the flap? That's what she's
Yeah,
asking.
yeah. Yeah, this is the also at the beginning. I wonder why this kind of capillary power has such a big power. Probably I I think something mysterious mechanism exists. Yeah, probably after isolating with this single power every time I'm watching the this small power that become show the very strong pulsation. So probably some yeah nice change of the vascular system occurs if flap become ischemic. Only a small vessel become powerful. In a normal stage, this capillary power has a not so strong power, but probably become ischemic because at the beginning, this capillary power, big capillary power rupture, some congestive or color is not so good. But
Yes.
1 hour after the flap transfer, flap color become gradually become a normal pink color. So that's why human or animal adaptability for the ischemia could be a very changeable.
Yes.
So probably this system. So every time I'm elevating power flap, big power in 80s, and gradually I use more smaller. Nowadays, I'm using the subdermal power rate, zero point 0.1 or 2 millimeter. And
Invisible capillary.
yeah, I trust that this is the definition of capillary power rate. So probably many standard flap are using a big pedicle could be replaced by this capillary power rate. Superficial power rate is enough because
Mm.
post-operative modality of arterial inflow and also venous drainage would be become bigger. So this is a human adaptability, completely same as the cortical re-education, controlling the cellular. Yeah.
Yes.
Now I'm this is a completely different story, but now I have a great interest of nerve palsy. Also, even though proximal facial nerve cell are completely damaged, hemilateral facial nerve are existed. Yeah, probably cellular cortical re-education completely control the hemilateral facial palsy because completely normal smiling occurs, independent muscle movement occurs. So probably human small organ, especially nerve and also vessel, could have great potential. Yeah, we have not yet noticed this modality. So year by year, I'm thinking the human adaptability is great. Not only vascular system, nervous system also. So that's why nowadays paraplegia could be a repair. Established paraplegia can started to work with simple nerve transfers. So this is a very important point. Yeah, I want to summarize Jessica's question, and probably nowadays AI summarize and clear up their answer. So probably everybody can learn from AI. Yeah. Thank you very much. Yeah, this is a very important. So I will not have such a clear concept, but now Jessica, noticed the very important concept. Probably everybody can share. Maybe 5 years or 10 years later, can understand this modality of human vascular system, especially capillary modality or animal modality of small capillary vascular system is great. So that's why flap will be
Yes, Sensei.
change from now, completely change from big pedicle to small pedicle. Okay.
Yes, Sensei.
So amazing about your lectures. So I focus on the procedure because I used to be a micro and hand surgeon, but now I follow Dr. Zhegang. So we mainly do the lymphedema surgery now. Yeah, that's very important for me to know the message from you because we not only one patient, we think about it. Diagnosis may be the ST syndrome, but at that time, the Dr. Nara from India also tell us the message from Kushima professor to the LVA for the patient. It's amazing because we think the ST syndrome is the sarcoma, angiosarcoma. Is this safe for this patient to do the LVAs? And then I want to know more detail about the LVA, like all your patients do only one incision or not. And the second question is it do the incision near the tumor or should choose the incision at the proximate of the tumor? Thank you so much.
Yeah, Sati, the voices are not so clear. So please, yeah,
Yes. Yes, Sensei. She was asking
yeah.
about your technique, the technique of
LVA.
syndrome, ST syndrome, ST
Uh-huh.
syndrome. Uh,
Yeah.
can you
Travis.
explain more? How does the LVA works in that? Is it
Yeah,
right,
only
Jingjing?
one LVA. If lymphatic channel is very strong power, probably only one LVA is enough. But if possible, as many as, probably power become greater. Yeah. So and also I had a recurrent case of C.R.A.Z.Y. 8 years later, recurrence occurs. For this case, I try lymph channel transfer with a multiple LVA. So after this surgery, pathology says tumor still remain. And also, I try a partial resection of tumor recurrence, but pathology say still tumor existed. But I try a lymph channel transfer with a multiple LVA. So this patient now 10 years after the secondary surgery, this recurrence, but she's completely surviving. She's a nurse and working completely normal work. So now 20 years after the primary surgery, but she had the previous LVA for lymphedema, and after LVA, C.R.A.Z.Y. occurs, angiosarcoma occurs. but tumor disappear. So previous LVA also work, working. So that's why prophylactic LVA in not only lymphedema, but angiosarcoma could be, repair, could be disappear if tumor occurs. So
That's
LVA is
amazing.
very important, not only cancer treatment. So anti-cancer immunity increased. Yeah.
Thank you so
With
much.
only this is also very, very important point.
She's asking about when you do prophylactic LVAs, for example, it is prostatic cancer or that other patients which you've shown in the femoral region, hybrid surgery. So do you do immediately and call it as prophylactic LVA, or do you wait for a few months so that the lymphatics get dilated and then you do it?
Yeah. Oh, this is also very interesting question. Yeah, if possible, simultaneous LVA is best. But many times oncologists at this stage don't believe the effect of prophylactic. So if we had not so nice collaboration, oncology always reject doing the prophylactic LVA. So in that case, secondary or early stage of lymphedema occurs as soon as possible. If some edema occurs, early stage LVA is very, very important. So can prevent progression of LVA. Very early stage. So diagnosis is now very easy. Early stage lymphedema is easy by use of body index impedance method. 10 years now I'm using this impedance water volume could be easily measured by impedance technique. This is very accurate. So early stage of diagnosis is very easy. But recently in Harvard or United States, some institutions are doing the some prophylactic LVA with breast cancer resection. But they reported recently publicated no significant difference between prophylactic also late stage LVA. I don't believe because my case, my series, almost all case prevented and the simultaneous LVA. The whole point of LVA result is depend on the doctor's technique because this is not a standard vascular anastomosis. This is a super micro. That's why, doctors who can replant the fingertip, such a technique are very, very important. So, real super microsurgeon can succeed fingertip replantation. Also, super microsurgical reconstruction, toe tip transfer to the fingertip. Those guys can have a higher success rate. So that's why I believe those real super microsurgeon, real super microsurgeon, the result is probably prophylactic LVA works. So it depends on the doctors. This is probably also Alzheimer. Probably also same thing happen. Real super microsurgeon can salvage Alzheimer. So training is very, very important. 0.3 millimeter vascular anastomosis with a super micro needle. Oh, this is a super micro needle is a very, very 15 micron needle yeah, I always encourage young microsurgeon to use 50 micron needle, 3 millimeter in length. This needle is essential for lymphatic surgery. Okay, yeah, this is also very important point.
Can you listen? Can you hear me?
Yeah.
Yeah, so because I think for sarcoma over the limb, usually after the resection, the defect is very big. So yeah, there will be I think majority of patients will suffer from different degree of lymphedema. So would you advocate a prophylactic LVA in these patients? And because I see in your presentation, some do have LVA during the operation, which is within the resection area. For some, you do it over the more distal area. So how do you choose when to do it at the resection area or to do it more distally?
This is also, many times, many doctors ask me, and usually breast cancer related lymphedema products are done in the axial region. Yeah, probably, this is the little bit dangerous because cancer cell may exist in the axial region. So I always doing the elbow fossa, distal region. So distal region, cancer cell never exist. Peripheral region, cancer cell or same area or cancer resection, everybody doubt the cancer metastasis. So if possible, try the distal portion. But difficult point in the distal portion is lymph channel is still functioning. Still have normal smooth muscle cell. So normal lymph channel show a very strong spasm. So if you touch a normal lymph channel, it become a shrink, and lumen become a very small, completely occluded. So that's why papaverine is a very important. Local use, not general use. Local dripping. So wait 20 minutes, a little bit longer. So any kind of lymph channel, spastic lymph channel become a loose, but it's not so long time, only 10 minutes. So during this 10 minutes, you must anastomosis, little wait and detect the dilatation. Also, I show you this today. C.R.A.Z.Y angiosarcoma case. I tried distal region, distal dorsal foot, because if I do the near area of tumor, probably many doctor criticize. Maybe cancer cell exists. So that's why I try a distal dorsal foot. But it works.
Yes, thank you.
Yeah, very important question.
Yeah, thank you very much.
Can you hear me?
Oh, yeah. You can hear. Oh,
Yeah,
nice to meet you.
Yeah, thank you, Professor. That's amazing.
You are a real super microsurgeon. You can salvage.
Yeah. I just saw you show us the amazing flap work about the lower extremity reconstruction, and you're using the ART flap to cover the donor side of the foot. I saw the palm side. So I saw you the details is you debulking the ART flap. after you harvest it.
Primary
Yes.
defect.
Yes. So I know JP have some technique about from when we dissect out the ALT flap, we can dissect out from the superficial fascial plane. From this part, we can harvest a very, very thin, like super thin ALT flap. So compare debulking after we harvest traditional ALT flap. Compare this technique and JP's technique. For your opinion, which one is better or faster, or which one is maybe safer? So I just want to know what you think about this.
Yeah. This is the very important question. So rough thinning may be okay.
Yeah.
So probably no need to use a microscope or ultra thinning. Probably it's okay because it's theoretically, I know intradermal layer, very rich vascular system existed. So with this intradermal vascular network, big flap could survive, but probably dimension is there is a dimension, limited dimension, maybe 10 centimeter from the central perforator could survive with very super thinning. This thinning technique reported by my junior doctor, Yamamoto, and also Narushima. Mastered my this rough thinning, but probably no need to use a microscope. Try to use this rough thinning. Probably flap could survive with only the intradermal plexus. Full thickness. Probably it's, but dimension is not so big. Dimension is limited. This is completely same with the ultra thin flap. Dimension is limited. If you need big flap, in that case, ultra thinning, maybe of course because peripheral region could survive with same mechanism as a full thickness skin graft. Oh, this concept was originally came from China. Chinese professor. I heard 90 first joint meeting with China and Japan in Shanghai. Shanghai 9th Hospital. First joint meeting was organized maybe 90. At that time, I forget his name. He's very famous. Now he died. He presented full thickness skin flap. So I asked him, this flap could survive on the bone. So he said, on the bone, it's impossible. But it looks like a flap because the dermal bleeding occurred. So this is the well vascular recipient are necessary. If a well vascular recipient, full thickness flap, ultra thin flap could survive, but on the bone, probably it's impossible. This concept already 30 years ago, 35 years, Chinese professor already established this concept. So these are the roots of my this thinning technique. This is a real history, background of thinning.
Okay, thank you, Sensei.
Yeah, welcome.
And I have another question about the super microsurgery, like LVA for lymphedema, because we all know you are the modern pioneer surgeons for LVA. You are first surgeon to start in this field from the 1999 or 1998. So, and you have 1,000 cases.
90 I studied. Yeah.
Yes. So yeah, I know. So how about the long-term result about LVA
Yeah.
and the NVA, like over 5 to 10 years follow-up? I'm still confusing about this part.
Yeah, now I'm analyzing the using the AI. I
Yeah.
have 3,000 case, and all case I make PowerPoint. PowerPoint memorizing, and also many cases has always checking the result with objective assessment using impedance technique. So not the subjective assessment. So this is very important. So I'm now analyzing using the AI and have several new data now appearing. So in general, speaking, year by year, over 10 years or 20 years, many cases show improvement. Never stop. Some cases become worse, but I always repeat LVA. Also, very severe case, I do lymph channel transfer, not lymph node. Lymph channel is powerful rather than lymph node, also less invasive. And year by year, 20 years, 30 years, many cases show a decrease. So that's why I always encourage patients, very severe patients, in future, your severe lymphedema will decrease. So this is very important point for especially severe patient. So you should come to me. I always care your severe lymphedema. So only the super microsurgeon can follow, and the patient believe those doctors. So we must always care and follow. Never give up. Even primary surgery doesn't work. We must continue. For their final stage. 10 years is a short period. 20 years or 30 years. Some patients now are coming 30 years and show the result. Many patients show the very nice. March size is very important.
Yeah, you just show us a very important information to support the young generation and super microsurgeons, because we sometimes we are confusing about long-term result about after LVA, because LVA is working very fast and the reduction is very quickly. So, but we are not, sometimes we are still confusing about how it can be maintained for a long time. How long it will be maintained. So you give us a huge support about this part. Thank you, Sensei.
Yeah, welcome.
And you mentioned about you also mentioned about the primary lymphedema. So in China for now, like in my center, we finished over 100, I think, primary lymphedemas in the last 2 years cases using LVA. But like from the last month, we start to try to know how about the thoracic duct and this part. Some primary lymphedema patients looks like have some problem at the central lymphatic system. It's not just about the limb, about extremity lymphedema. So I have read some of your papers talking about you just using LVA can handle some tiny case, like some infants, some little babies, a very severe lymphedema, and just using LVA. I have read your papers. So how do you think about, can we do some surgery about duct, this part, just doing some surgery for the central system, lymphatic system. Can we use this technique? And this is safe, or how about the long term about this part? Because I try to start to do some cases, but it's the very cases, and I searched from the PubMed like a few papers talking about this part. So I hope to get some answers or some experience from you, because you are superstar. You are joint.
Yeah, this is primary lymphedema. Many times combine the central problem. Central lymphatic system also have a problem. So that's why at the age of 20 or 30s, some patients die because of septic shock. So that's why primary lymphedema, we should try the LVA in the early stage when the children or babies. First, we should try the distal LVA in the leg, also groin region. Sometimes the groin region, reverse flow of lymphatics from proximal to distal existed. Those patients show a dramatic recovery. And during surgery, you can see a chiral reflux in the groin region. So those cases show that dramatic improvement occurs after surgery. But some case doesn't work because the chiral reflux, because the valve system broken. In that case, chiral reflux occurs. So extra-abdominal, extrathoracic lymphovenous anastomosis works very well. But some cases has still valve system function. In that case, reverse chiral never occurs. So those cases need an intra-abdominal LVA. I tried intra-abdominal LVA several cases. Mesenteric LVA, lymphovenous anastomosis, or lymphochannel transfer to the mesenteric region. Not so many, but if I have a long time follow-up for this case, show a nice result. But even at those cases, problem occurs, pneumonia, and also some other. Sometimes septic shock occurs. So always collaborate with the general surgery and the thoracic surgery. So this is a very important point. And probably those patients need LVA, intra-abdominal LVA. Repeat. Also, extra-abdominal LVA, both are necessary. And also lymphochannel transfer. But donor side also have chiral reflux, lateral thoracic area, or whole area, whole lymphochannel, whole body. Not complete. Valve system. Many times valve system broken. This was completely, already proved by the animal. Same, primary lymphoedema could be, occurs in knockout mouse. So mechanism, gene, abnormality are also, known by the fundamental. So fundamental research doctor or lymphatics, and also collaboration with me, clinical doctor necessary. From the beginning, I always learn from research doctors. So that's why I learned the smooth muscle cell existence within the lymph channel. Also, lymph channel contractions with the smooth muscle cell, and found degeneration of human smooth muscle within the lymph channel. I first found using electron microscopic examination. This was middle 90. So that's why after this observation, I can establish a concept of dysfunctioning lymph channel. in a human lymphedema. So theoretical treatment, lymph channel transfer created. Also early stage LVA works, and also prophylactic LVA. Everything are based on this degeneration mechanism of smooth muscle cell. So this theory always establish absolutely correct treatment, surgical treatment. This point is very, very important. So you must learn fundamental knowledge, physiology, and also biomolecular or lymphatic system. Also gene abnormality. Also immunity is more important. That's why today I notice anti-cancer immunity increase with LVA. So this is also very, very important. So knowledge of immunity is also very, very, so we must learn many things. The lymphatic system, not only anatomy, especially molecular biology of lymphatic system is now also gene abnormality, also primary lymphedema. Many times gene abnormality are related. So this knowledge is very, very important. So collaboration with research specialist is also very important. Okay, thank you. Very last question.
Okay,
Thank you. Thank you. Thank you.
Yeah, okay.
Just
Thank
one
you,
last question.
We are in my hospital. We are looking for a doctor to take over Dr. Koshima's technique. Please come to Hiroshima. Good night.
Yeah, Hiro Sensei always welcome to the foreign young doctors to master supermicro. Now he's completely a master supermicro lymphatic dissection technique in only several months. Yeah, he's old, but his technique is very, very nice. Yeah, very fast to get it. Supermicro technique. It's amazing. Always I'm amazing. Yeah, his technique is better. He's the first successor of dog lymphadenopathy. In the United States, he showed his technique. It's the middle 70s. So he's the first successor of technique of lymphadenopathy. Okay. Yeah, thank you very much, Hiro Sensei, every time. So please,
Yeah, thank you.
Sati, you take a picture?
Yes, yeah. Thank you again to our distinguished speakers. I know Dr. Baba had to go, but thank you, Professor Koshima, and also to Dr. Sachin Chavra for organizing this vital session. So to all the participants, before we leave, thank you for joining us at this early hour in Japan, India, and across the world. We hope you will join us for our next meeting. And before you go, we're going to take a group photo. Okay, so turn on your videos, please.
Will you able to take, Jessica, or shall I?
Can you take it, please?
Yeah, I will take. Yeah, okay. So all of you, please on the count of 3, I will take a photo. 3, 2, 1.
Okay, thank you very much.